Good afternoon and welcome to the 65th of the COVID Calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at Drexel University in Philadelphia. Today we have a discussion of COVID-19, race, and the healthcare crisis with Nick Ramos and Danny Ritchie. You can catch COVID Calls live every weekday at 5 p.m. Eastern Time on YouTube Live. Just go to the COVID Calls YouTube channel to watch. You can hear COVID Calls recorded as podcasts on podbean.com or iTunes or on Stitcher or Spotify, anywhere you get podcasts. You can also keep up with COVID Calls via Twitter using the handle @US of Disaster or @COVID Calls. Please do help spread the word and send suggestions for guests and future topics, and please feel free to suggest yourself as a future guest. As of today, June 12th, 2020, there are 7,578,078 confirmed cases of COVID-19 globally, according to the Johns Hopkins University Coronavirus Resource Center. That's up from 7,440,350 cases reported yesterday. Of those, 2,036,429 are in the United States, up from 2,013,940 reported yesterday. There are now a total of 114,195 deaths reported from COVID-19 in the United States, up from 113,467 deaths reported yesterday. As a way to bring some humanity to the numbers, I've been reading a life story every day, and I'd like to continue that now. Headline is Winifred Fredericks, civil rights activist and community advocate, dies of coronavirus. This is written by Deborah Fougere, and this comes from New York One, May 20th. Winifred McDonald was just 10 years old when she met the man she would marry at a community center in Harlem. Maurice Fredericks was 13. Even though fate forced them apart, their destiny could not be denied. It would take 10 years, but they married in 1947. Their daughter, Adele Lee, said it was love at first sight for her mom. My father was an extremely intelligent man who had a good command of the English language, Lee said. My mother was very much attracted to that and always told everyone that he won her over through his letter writing skills and his beautiful penmanship. Of course, his good looks helped as well. Twice a month, Lee brought her mom with her on visits to the Cobble Hill Health Center, a nursing home in Brooklyn. It was part of Lee's outreach with the Brooklyn Tabernacle Visitation Ministry. She said her mom loved telling jokes to the residents there under her own watchful eye. She liked to tell X-rated jokes, Lee said. When I told her from time to time, "You can't read this one," she'd be upset. She couldn't understand why. I'd tell her we're representing the church. In late March, Fredericks' home attendant noticed her blood pressure was dangerously low and brought her to Staten Island University Hospital. A day later, she was told she tested positive for the new coronavirus. She was treated for pneumonia and sent home. 3 days later, she was finding it hard to breathe and was hospitalized again. She died on April 8th, just 10 days before her 93rd birthday. The ironic thing is that now, not only will she no longer be there at the nursing home because of COVID-19, but many of the residents she ministered to also lost their lives to the virus, Lee said. By the end of April, the Cobble Hill nursing home had at least 60 coronavirus deaths. Winifred Fredericks' story is about love, and it's also about courage. She was born and raised in New York City. She worked as a legal secretary. Her husband, a World War II Navy veteran, became a letter carrier. They moved from Harlem to Brooklyn 2 years after they were married and stayed there together for more than 60 years, and together they became a part of history. My mom and dad were very much involved in the civil rights movement in the late 50s, Lee said. They participated in the 1957 March on Washington, led by A. Philip Randolph, Dr. Martin Luther King's march in 1963, and the Freedom Rides down Route 40 with the Brooklyn Congress of Racial Equality. They were part of the Stall-In on the opening day of the 1964 World's Fair, a protest against job discrimination, police brutality, and the inferior schools and housing. They protested against Brooklyn's famous Ebbinger's Bakery, blocking trucks, picketing, and boycotting to end their discriminatory hiring practices. They took part in sit-ins against the Board of Education and demonstrated against the Vietnam War. I admired what they did because when I was a teenager, I joined them on some of those picket lines, Lee said. I saw what was happening. I saw the things they stood for. I really admired their bravery and commitment. They made a commitment and stuck to it. She had a busy social life, was a dedicated member of the Bethany Baptist Church and AARP's 2197 Brooklyn chapter. She worked with her local block association, and she loved to travel, visiting Africa, Europe, Caribbean, and Asia. And she made her twice monthly nursing home visits with her daughter. The residents always told her how much they appreciated her involvement, Lee said, and they looked forward to her being there. My mother was loved by all those she encountered, Lee said, and she will be sorely missed. She was a silent person, but strong in her own way. My family and I were very blessed to have had her for as long as we did. She was 92, yes, but COVID-19 stole the few remaining years she could have had. I'd like to turn to the discussion now and introduce my guests, two great guests today. Nick John Ramos is an assistant professor in the Department of History at Drexel University. He is currently working on his book manuscript, Policing Health, Making Race, Sexuality, and Poverty Productive in Global Los Angeles, 1965-1986, which examines the interlocking relationships between the rise of prisons and policing and new spatial forms of segregation, like Skid Row and new healthcare institutions originally built as anti-poverty projects, such as neighborhood health centers, community mental health centers, and emergency medical systems. He just published an op-ed article. You can see I put that up yesterday on my Twitter page at US of Disaster, or just go to the Made by History section of the Washington Post. You definitely want to check out this wonderful op-ed that Nick has written. My second guest, Danny Ritchie, MD, MPH, is University of Chicago Pritzker School of Medicine graduate, completed residency in family medicine. Sorry, that seemed to have gotten one thing out of order here in the biography. So let me just move on. She's an expert in race, class, gender, and policy, and looks at the way that these reproduce health disparities and inequity, and medical students on the social and community context of health. These are the areas that she teaches and studies. She spearheaded the passing of RIGL 2364.1, forming the Commission on Health Advocacy and Equity of 2011. It requires health disparities reporting and diversification of the health workforce, such as community health workers. She is on the APHA, CHW Section Policy Committee and Education Committee, and the CHW Caucus, the HHS, NPA, and Region 1 Health Equity Council. She completed her training in family medicine at the residency program of social medicine at Montefiore Medical Center and Albert Einstein's College of Medicine. She came to Brown University to pursue health service research, and she completed her master's in public health at Brown in 2003. She works from community to the policy level to shift perspectives, working to increase the community embedded CHW workforce that can implement programs to address community priorities. So with that, let me welcome my guests, Danny and Nick. Thanks for coming on COVID Calls today.
Glad to be here.
Thanks for inviting me.
Danny, I'm sorry that I bungled the first line of your biography there. I really apologize for that. Did I get anything?
No, it was fine.
wrong?
I think it works either way, really.
Okay, I got it reversed, and I apologize for that. It looks like I transposed something when I was put it together. And I can't wait to find out more about all of your wonderful work. Let me start by asking you both a question that I've been asking all the guests, and that's just to find out where you're calling in from and how things are there with the pandemic. And then also, if you're willing to say a little bit about it, how things have been with the protests against police violence and the killing of George Floyd. Can I start, Danny, with you on that?
Wow. So how are we doing? So I'm calling from Providence, Rhode Island. So I'm still affiliated with Brown and have an organization called Community Health Innovations of Rhode Island. And so Rhode Island is a small state. You know, we have about 1 million people, and we've been in the forefront of doing some innovative things, right? And we're led by a woman governor, and our health department is led by an African-American woman. So we have 2 women at the lead who've been taking the lead on this. And but I can't say that we haven't been hampered by, the issues around a public health infrastructure that has been decimated for decades, as Nick talks about in his article. And so that it's, we were struggling in the beginning to get the equipment we needed, competing with other states, and we're a tiny state. And but we managed. Just having equipment, the tests, the PPEs, and so on. So our cases, though, reflect the disparities that happen across the state, and we actually have an unusually high percentage of Latinx people with coronavirus. We had estimated, they were shocked to find out when they finally started teasing it out, 45% of the cases. Yeah. And and I would like to say that I think that because we have a commission on health equity, that it requires a report every couple of years, that are presented to the legislator and our governor, and that was passed in 2011, so that understanding disparities, and this was the first year they actually started doing benchmarks by look at the social determinants of health and seeing the disparities across, education, housing, and so on, that it's not a shock. You don't have to start to teach people about what this means in this time. So our governor knew when our director said, we need to be making sure that we're having an equity lens. It wasn't a mystery, right? They're now also doing probably one of the first piloting of looking at the serologies, to start to get a much more of a handle on what the general population infection is. In reality, we should have been doing this months ago, but
Right.
Where's the infrastructure? Where's the money? Where's the support to do this? And we are not going to make up for decades of a decimation of our public health system. I could tell you, I think, Latinx people, turns out that they're about over three times as likely to be infected, and African Americans are 2 times as likely. And the serology tests showed that, again, that there's 8% of those were tested for Latinx, 5% for African Americans, and I think 0.9% for whites. So yeah, that's where we are.
I want to dive into more of that in just a moment. Nick, let me get first from you where you're calling in from and what the situation is there.
I am calling from South Philly, in Philadelphia here. We're sort of in a weird moment here because, we're still in the pandemic, but, the city is reopening business. So today is, where many businesses are yellow, what the governor calls the yellow phase. And so I've been receiving emails here and there about, reopened restaurants, reopened businesses, and still people are weary of going out. All of this is happening in a city where we've seen some of the most well-attended protests around George Floyd, Ahmaud Arbery, Breonna Taylor. But we've also seen some of the most repressive aspects of the city's police force. We've also witnessed here, a little bit of a sort of white vigilante citizens patrol. And this accounts for why we've seen such a strong showing in the United States is the largest, poorest city in the United States. Why folks have really come out to say, we need funding for the pandemic, and we also need to defund the Philly Police Department by $120 million. So that's sort of what's going on around me, and I'm just trying to be really attentive to all of it.
On Monday, God, was that this week? I guess it was. Nick and I are colleagues at Drexel, and we had a teach-in, and we had 70 students, faculty, and staff participate in that, sort of a Zoom teach-in. And I wonder, Nick, if just to stay with this for a second, what kind of we had a lot of feedback from students on that. Did you hear anything in particular in that really moved you, or you thought really was reflective of the tensions of this moment? I was deeply moved by much of what I heard.
Yeah, I really, we were joined by students who are plugging themselves into actual organizations that are grassroots organizing, that they've linked themselves up with organizations involved with Philly We Rise, phillywerise.com if you want to check them out. And that was to me inspiring because it reminded me of the lessons that I just imparted to my students in my U.S. Civil Rights Movement course, which is people have been organizing for a long time for this moment. And, the defund call does not come out of nowhere. And what I loved is that these students knew that and they understood that. And so that's the one thing that I really took out of that. And I look to the youth to lead at this moment in time. I told my last meeting with my class, I said, look, you're inheriting this world. And it's time that, that you tell folks what kind of world you want to step into. So I'm glad to see that.
So we're going to get some history here to start. Maybe I'm going to stick with you, Nick. And I'm going to just read a couple lines here from your op-ed piece in the Washington Post and see if you can help us with this a little bit. So you said in this piece that since the 1970s, we have valorized expensive drugs, technology, invasive procedures, and intensive labor arrangements to save us when we are at our sickest, rather than address non-medical and public health approaches that prevent the onset of serious disease when we are at our healthiest. This shift towards an acute care and emergency-focused system, however, was not inevitable, but the result of decades of public policy rooted in the aftermath of the 1960s uprisings. So can you draw these things together for us? I know there's a lot. It's like your book project and your research and the op-ed, but just to sort of lay some groundwork for this conversation, these policy choices that come out of this previous era of civil rights activism, and the obituary that we heard today leads us into this a little bit, to understand some background of how we get to this discussion we're having today.
Well, the funny thing is the way that I came to this project is that I had read and was inspired, like many folks in this moment, by the work of Ruth Wilson Gilmore and her book Golden Gulag. And in that book, she really talks about how the rise of policing comes out of this moment in time that most people narrate as a kind of pulling back of taxpayers' willingness to give up their money, right, through taxes to government. And so what she looks at is that the pot that we were left with after citizens revolted around taxes is we continued to allocate those money, that revenue more and more towards policing. And so my work really looks at to see how we didn't actually stop funding. We didn't stop giving money to public health. The way that we gave money to public health changed. And in particular, I look at how that shift moved towards emergency medicine, which is a really ill fit for democratic medicine, right? And it's extremely cost prohibitive, a very specialized form of medicine. And yet we've put so much money into it at the same time that we put money into militarizing the police. And so what my work thinks about is how that shift in tax revenue, just sort of where the lines go, right? How we shifted the center of public health to be away from preventative health towards emergency medicine really says a lot about how we've chosen what our priorities are. And for me, the moment that clicked for me was the moment that I stopped seeing emergency medicine as a public health feature and saw it as a public safety feature. And we have to kind of, one thing that I didn't talk about in the op-ed, but is in the book manuscript and the research, is how, this new thing called emergency medicine really came to most citizens. Most people came to know it not only through television, but through the gunshot wounds and stabbing victims that the United States said that we have no responsibility for, right? Local communities say we have no responsibility for that violence, unimpeded violence on the streets. So at the center is all of this is a concern around Black life, and just sort of the devaluation of Black life in American cities. So that's sort of what I'm trying to pay attention to in the work. But this means we've just seen, where the money could have gone to putting roofs over people's heads, food and nutrition programs. Those have just, the budgets have, the line items for that have just gone skinnier and skinnier. I don't know, Danny, if you could add anything to that, but
I'm chomping here. We should have more conversations. I think that if you don't mind, I just, so what I hear in that shift is how, and I would like to have more emphasis on how we have market decisions for everything, to run everything. And we want our hospitals and our healthcare to work as a transactional service, right? You give something, you bill for it, and then, and it goes up. The more technology you do, well, that's more money that you can get. And so we're incentivized to keep running this procedure-like system in order to validate the reasons of, to get reimbursed for the work that we're doing, instead of understanding it as taking care of people.
Yep.
And so I think, you did really well about showing like how here we are in this crisis, and now because we don't have elective surgeries or elective procedures, and there's a decreased hospitalizations, these hospitals are, and clinics are going broke, right? And so now they're having to lay people off. So the incentives of what we've modeled, so then you've modeled a public health system also around a clinical model, right?
Yep.
And not about a population health model. And so we see where we are. Right?
Yeah. I mean, at the end of the day, clinicians have to make a billable procedure, right? When they put in something. And some of the things that we're saying here that really produce health and sustain health, like housing, food, employment. These are things that doctors can advise, but that's not billable,
Right. Yeah.
Nick, if I could just stick with this for a minute, why that particular moment? What's happening? I mean, we often in American history, we've I think incorrectly in our historiography, we sort of point to the 60s as this great moment of excitement in the streets, reform, and then the 70s are kind of forgotten. That whatever hardened from the 60s is kind of, we moved along quickly into the 1980s. But what you're suggesting here is that there's some pretty profound shifts, structural shifts that get hardened by already maybe moving into the Reagan years. Can you say a little bit about that timing of that?
Yeah, I mean, one thing that the work looks at is how, the anti-poverty programs that began in the 60s really started to focus in on these things that we would now call social determinants of health. Jobs, housing, employment, food and nutrition, childcare, but by the 1970s, what I see is the rise of biomedicine, particularly in amongst large research academic medical centers, is the incentive to do high, labor intensive research on procedures and drugs that moved medicine away from that. And so what you got was, even within medicine, within even some advocates of community mental health, was a call to sort of align themselves with the kind of movement towards quote unquote research medicine. And so some of that comes out of this, right? a lot of this too comes with the fact that these programs that most people use the term welfare as a shorthand for them. They became associated with communities of color, and so this is sort of a long swing towards Reagan in the 80s. But I really look at how all of this is happening in the 60s and 70s, right? And these anti-poverty programs were not funded enough, and so but through the sort of citizen participation mandates that mandated that communities, poor communities, be involved in the sort of implementation of anti-poverty programs, lending themselves by the 70s for people to say, well, it's clear that these poor people cannot pull themselves up, even if we're giving them this money. And so the sort of ethos became, there's nothing that we can do to change the culture of these folks. They're poor because of their behavior, of their culture, and those are poor excuses for larger structural issues that face poor people, particularly of color.
So let's bring this up to COVID-19, and Danny, I want to ask you. I mean, it's a deceptively simple question, and I think with a very complicated answer that I want to explore with you, which is, why is it that we look across the numbers today in the United States and communities of color are just indisputably more susceptible to higher rates of COVID-19 infection?
Is it that they're more susceptible, or they're exposed more? All right. So, I think we've noticed, and there's been a lot of discussion about the essential worker, the frontline worker, the grocery store owner, or the grocery store clerk, and the CNA, the people who are in the hospitals, and then the janitors, and it gets, so there's more exposure, here in Rhode Island, and I'm sure everywhere, there's the issues around labor, immigrant labor, right? And so a lot of so what we're thinking and we're seeing in the Latinx community are, immigrant labor that's being exploited. People working in factories, we actually find that people are being, by the companies, transported in closed systems that don't have space, and then they come home and they're living lots of people in one place. If you're on the transportation system, there isn't enough space. There aren't enough buses. And so they actually just today added that in their screening, they're noticing that it's bus drivers and restaurant workers. So all of these people, so who's in the back of the restaurants, right? And so it is, susceptibility has to do with the social structure and who works where, and for what. And the fact is, they can't not work because they won't eat. They won't eat.
Yeah, I would say that, to add on, it's the compulsory nature, the almost compulsory nature of that exposure. We're really witnessing the kind of extremes of a global economy that has really racialized the essential worker, as Danny is saying here, as a kind of necessary but oppressed category of labor. The way I think about it is that we've really sort of held the essential, you've seen this in memes, that, we've really held essential workers hostage in our society in order for our society to operate. Right. But, this is the historical tie-in here, is that, this nation has been holding Black people's labor hostage for generations. And we could talk about this during slavery. We could talk about this, with slave patrols and with the police forces as sort of being the kind of enforcement mechanisms to really, quote unquote, keep people in their place. And so part of my thinking is that, the compulsory nature of labor then really means that essential workers have a higher frequency of contact with people, which then means that, of course, they're going to have a higher rate of acquiring the virus.
Right.
And as what Danny is saying is that it's compounded by a kind of historical concentration of poverty in particular neighborhoods, and that these neighborhoods reflect the kind of segregation, the forces of segregation. Here I'm thinking about, racist policing, racist real estate practices on the part of banks, real estate agents, and homeowners. And that means that folks are going home and exposing their own loved ones who are also working, right, or and trying to survive. And so the way I think about it is that for most people, coronavirus exposure really is not a choice. It's a mandated work hazard.
Right. I mean, I think that you really, and that's a really important distinction, because I think that we have a society that wants to blame the person, of color, the marginalized person, say it's something about their biology. I would say, and I know that you had wanted to talk about this, is that yes, people, they carry a larger burden of other diseases, which is why they're having worse outcomes, right? Mm-hmm. And those other diseases are, because of the social systems that are structural, in a way that oppresses them, and they're carrying that chronically all the time, which allows them to have more of these chronic diseases. So those are, so there's two things that you're seeing, but because we have a discourse in our society that somehow, these folks just not, they're just sickly, they're not meant to survive.
Right.
And that's a long history. Yeah. So it allows us to, instead of understanding them as the canary in the coal mine, right?
Yeah.
And, we really have to get to understanding how those that are disproportionately burdened with carrying the society they end up having the greater burden of sickness and illness. But it does not mean, but others also suffer from that. And the statistics show it. And you talked about it in the number of COVID cases that we have in the United States. We have the largest disparities in the world. I mean, in the industrialized world. And it has always been that we have the largest disparities and we have the worst health outcomes. We might have extended life expectancies, but when you compare it to other places that don't have as many disparities, our life expectancy is worse. So across the board, not just the most marginalized. We can't be doing this dichotomous rich, poor, the poverty, but no, it's you look across the board and you go through every income bracket and they will have worse outcomes than elsewhere. So we need to understand that what we do is impacting everybody.
Mm-hmm.
Right. Mm-hmm. I want to remind people you're listening to COVID Calls. We're talking to Danny Ritchie and Nick Ramos, and I want to stay with this. There are a couple key things here to me that I'm learning a lot about right here. I mean, one is this important point that was made about the health burden in communities already, which might then, and so if you don't think about that, then that will immediately skew your thinking about who's more likely or less likely to have certain health outcomes with COVID-19.
Right.
Mm-hmm. And I think there's a tension there, though, because, and even as I do, I read the statistics, I read these numbers because I think they're important. We need to know them every day. We need to be aware of them, and yet those numbers and so much of the public health information that's been given to us, it feels very much like a dashboard. It gives us some sense of control, some sense of monitoring, but it doesn't address, Danny, what you're talking about, of this sort of burden of disease, and even of stress in communities. And I don't know the way out of that. It's like a health communication problem. You want to communicate clearly about the scale of the disaster, but then, people are often not given, public health directors or even Anthony Fauci, they're not given that second sentence or that third sentence, or not to mention the fourth. How do you think about that difficulty of communicating what we just talked about?
So I just said that it has to do with our societal discourse. We kind of repeat the same lines over and over again, and we never talk about the root causes. So people don't have a place to go to think about it differently. They're just hearing, oh, yeah, well, they're sick and they're dying. Well, yeah, oh well, yeah, that's the way. That's the facts. That's the way they are, and they don't get the other portions of understanding the oppression and the impact of our structural violence and our racism, our structural racism, and the ways, and all of the isms, right, that people are impacted with. There's no place to think about that, so they don't see how that sets people up, right, and how to have to end up addressing that in order to make a change, right? So where do you have to make the change? It just becomes this, that's just the facts. That's just the way they are. And the issue is that even for when I'm talking with students, I give a course called Policy, Culture, Discourse that shape health and healthcare. And the fact is that they come because they feel like they'll take a class and that nobody ever talks to them about why there are health disparities. They just go, health disparities. Okay, look, health disparities.
Right.
So, and there's no real explanation of it. And so also, since we have a legacy of hundreds of years of expectation that if you are a person of color, that you're more sickly and you're bound to die out, then well, there's just nothing we can do about it because that's just your predisposition. It's very, yeah.
It makes me think, to come to the other part in the previous part of our discussion that was so important is about this. Nick, you talked about essential workers, and the sense in which African Americans have been subject to slavery and to forced labor of all types in American history. And I'm thinking about in the 1790s, even in Philadelphia, the yellow fever epidemics that we had there. And it's kind of become sort of famous, at least famous in Philadelphia, that the president left, the Congress left, everybody who could leave left the city.
Right.
And the mayor stays, and you get a few public officials who stay, but everybody who's middle class, certainly elites, left the city. But the African American population, some of which is slave and some of which is free, remains because they don't have freedom of movement. And Richard Allen, who founded the Mother Bethel Church, and Absalom Jones, they're sort of forced into service, organizing the Black population to tend to the sick, to tend to the dead, to build coffins. And they become the essential workers of the 1790s. They're free to demonstrate their commitment to the population, but they're not free to say no. And of course, the assumption at that time also is that because they're Black, they can't get yellow fever. This was the assumption of the white medical establishment of the time. And they've been very much on my mind lately, and that problem has been on my mind around this sort of the use of the term essential workers and what it obscures. And Nick, I just wanted to dig a little more into this with you because
yeah, this is really fascinating. I've been actually thinking a little bit more about another epidemic, the smallpox epidemic, after in the midst of the Civil War and emancipation, those who believed in scientific racism used it as proof that the smallpox epidemic was a Black disease that showed that that Black people were incapable of living outside of white patronage. But then there's another sort of Freedmen's Bureau argument around this, how to get rid of the smallpox epidemic. And their answer was, well, we need to send Black men back into the fields. Because once they start earning, then they can start taking care of their families, and therefore we won't need to take care of this epidemic. Each Black household will. And so if you look at some work by, folks like Jim Downs, for instance, this sort of instantiation of compulsory wage labor in the South comes along with the reinvention of the state hospital in Georgia to separate, quote unquote, dependents from the able-bodied, right?
Mm-hmm.
And the able-bodied meaning literally workers that need to go back into the fields to kind of, revive the country back into its economy. And it's been on my mind because, again, it's sort of this moment, it's this kind of twist on this moment of freedom that is actually unfreedom, or a kind of new creation of a labor arrangement. And that's the labor arrangement that we live with today, and I think is more salient, right? And part of the reason, the kind of odd, rhetoric of Trump that, the way to get around coronavirus is to send people back to work. I mean, it's still, it resonates. It's not the same. But that's actually the epidemic I've been thinking a little bit more about, because it points to the kind of labor arrangements that I think are at the core of the epidemiology of coronavirus.
It seems, I'm just looking at the yard signs that are out there, at least in my neighborhood, praising essential workers.
Mm-hmm.
There's maybe one that says we support essential workers, but there's others that differentiate. We support health workers and essential workers. I've been trying to, it's not scientific, but just take stock of the fact that there does even seem to be in what you would think would be another moment for a sort of, let's talk about this, let's talk about the roots of this, let's possibly look at this as a moment for truth-telling and reform. But there's this differentiation that's made between the essential worker, which is the healthcare worker, and then the other essential worker, which may be, and all of the sort of assumptions that go into that, what communities they live in, their race, their status in society. But that word essential is doing something right now. It's doing a sorting right now, which I'm a little worried about.
So it sounds like you're kind of talking about a class distinction, right? And how we want to separate them in terms of, like that they're, there's the essential workers, but they're not the same as those that are the healthcare practitioners, right? The physicians, the nurses, and and they're so different than the clerk. So I'm a physician, and
essential worker.
I'm not. I don't do clinical practice now, so I'm not on the front line like that. But I've always understood myself as a worker, right? And so that's another, thing that we try to make a differentiate in our society, that we're somehow this elite class and we don't have the same issues as others because we're this special group. And the fact is like, no, there are no PPEs. That you have to be in the hospital and you have to work without it. How about a garbage bag? So that's the, and the fact that, that people have been allowed to think of themselves as somehow distinct is, another conundrum and issue that we don't really talk about. I mean, who's making the money in those hospitals? I don't think the CEO is exposed like the physician is. And let's look at his paycheck.
Yeah.
There you go. I want to remind people you're listening to Code Calls. I'm talking to Nick John Ramos and Danny Ritchie. I have a question that came in actually from Amy Slayton. And here's the question. Is it worth critiquing cultural claims that medicine and bioscience naturally represent leading edge human knowledge? Itself a concept that historically buttresses whiteness, U.S. exceptionalism, etc. Nick, let me throw that one to you first and see if you want to think with that at all.
Yeah, I mean, one is the way, one is the way in which, the image of the white physician has always papered over the existence of other, um, you know, uh, medical traditions. In fact, when I teach my course on the race and history of medicine, is we begin with how you see European practitioners really learning from enslaved Black people, enslaved Black healers. Really learning from colonized people in India, right? The sort of might of British medicine comes directly from stealing medical knowledge from the folks they colonized, and papering over the fact that that knowledge, in the hands of these European practitioners becomes Western knowledge, right, at a certain point. And that the sort of birth of surgery and the things that we associate now with sort of like the fancier, more labor-intensive, biomedical focused traditions in medicine really come out of, they're only made possible by the ways in which certain populations have been made vulnerable by slavery and different labor arrangements. So, the birth of gynecology comes, in the United States, really comes from, we owe it to Anarcha, Lucy, and Betsy, who were enslaved women that were experimented on by Dr. J. Marion Sims. So these are sort of ways in which that what we count as sort of quote unquote Western knowledge and the kind of white physician is really made off of the knowledge and really like harmful invasion of people of color, right? But I would say too that the more damaging thing is how medicine since the 1960s and 1970s, this moment that I look at, has separated biomedicine from other forms of health. And this is what, to go back to an earlier conversation, is, having a roof over someone's head is just as much about health as it is about, writing a script or carrying out a procedure. One is more valued.
More so.
Right? Mm-hmm. One is more valued than the other, right? And so, we're so fascinated and amazed by that technology, the sort of miracle the sort of miracle of these really invasive and really expensive procedures, that we don't focus on kind of the everyday aspects of health. I'll stop there. Danny, I know that you're
thank you, Nick.
Yeah, so I'm a social medicine physician, and the fact is that social medicine was coined by Virchow, who was an Austrian and German physician. He worked in Germany. He was Austrian, and it spread across the world. It's social medicine, and that was the tension, and it was around the time of revolution, right? Yep. And the tension at that time, that there was a real look at the social aspects of disease and understanding poverty and what was setting people up for disease. And so there's been a tension since then, and so the biologization, becoming. It is starting in that time, because that's when you're seeing the gynecologist, you're seeing the physician, the rise of the profession of physicians, and they're claiming special knowledge and then using people of Black women, especially in gynecology. That is really the rise of this the journals and this research and the science, and creating their special class, right? As you're saying, on the backs and bodies of Black women.
Yeah.
So that it's, and then, and so when you have penicillin, that comes in, and so that you can start to just reduce everything to, look, we found a cure for this biological thing that's happening here. And so there you go. We don't have to talk about the social. Bye.
Right. Yeah.
So we, again, don't have this understanding about how much more of our social systems actually contribute to the poor health outcomes.
Except that, as you were saying earlier, Danny, when in a sense that even though we may have the penicillin or we may have whatever kind of cutting edge medicine, it's not distributed equally. So, the assumption there would be, yeah, even if you had the techno fix or the biological fix, the good medicine, whatever it may be, then that would apply across the population. But as we were discussing earlier, that's not the way that has played out. So if you went wholesale into the idea that, no, just everybody should be able to get this medicine, we know in practice that it hasn't worked out.
Well, it just goes back to the transactional issue, right? It goes back to who are you able to extract the funds from, right? They're going to be people who can afford it, who have the insurance. And if you have bad insurance, then we have to figure out how to do a markup. So why you might see more C-sections among, unnecessary C-sections in African-American women who are, well, anybody, right? Just so that you can do procedure.
Right.
But especially for those who a natural birth doesn't really bring as much money.
I want to just make an observation here in speaking to both of you, which to me is this amazing continuum of history into talking about public health as it is. And you're kind of almost finishing each other's sentences, which is amazing. And
it's
Danny,
always been that way between us.
Yeah,
it's great. I mean, I think it speaks to a pedagogy. I mean, I think it speaks to a mode of teaching and learning that I hope is being practiced, is reproducible. And Danny, back to something you said earlier about public health education, in which students are told, here's the list of social determinants of health. But so let me ask you just a bit about your own experience as a learner or as a teacher. Is there much there for those students to get so that they can get a handle on this background, so that they know the social determinants more deeply as structures that are come out of roots of, these have systems, they have power, they have...
Look at my face.
Okay, thank you for answering that question. This is a podcast too, so I want to make sure that people know that the face she was giving was the face of the raised eyebrow, but go ahead.
So yeah, I would have to say that, so I decided to go into the work that I do is, much more community grounded and looking at how do you, and I think we should get to this, what makes a community safe, right? What makes us safe and healthy? And so we can get to the police stuff, right? Because that's not what's making us safe. And what makes us safe is housing, having, nutritious food, having an excellent education. That outweighs and makes us more healthy than any testing that we can have, any kind of screening that we have. It has much longer, carries much more in improving our health. So I left the clinical world, not because I wanted to, but because I didn't get support to do the work that I wanted to do. But I said, if I'm a true, primary care prevention, I need to be getting to the problem before it happens, because by the time people come to see me in the clinical setting, it's late.
It's too late. Yeah.
It's too late. So, and I basically was told, well, we don't get paid for that. So goodbye. Good luck with that. Really valuable, but so, okay.
Yeah.
So I'm not sure. It's probably more ad hoc according to what instructor you might get, that might give you more of an idea about what the structural issues are. But the kids that I teach undergraduate, not in the public health not in the medical school, are coming to me because they're not finding it
In other places, yeah.
in the
Yeah.
other places.
I mean, this
Yeah,
is
that's
this
great.
is really
Thank you.
the shortcoming of graduate medical education or medical school education in general, which is medical school only teach you how to use things in a medicine bag well. But when you get into a clinical atmosphere, you're realizing that you could treat the wound or the immediate biomedical affliction that's in front of you with the patient, but that wound or whatever that affliction has is connected to a sort of social world that may actually return that wound or have an affliction somewhere else. And for doctors, this is the difference between curing a biomedical affliction and actually being a doctor who gets in to make sure that the people that you see are healthy. The distance between those two points can be leagues. And that means when I talk to medical students, I always tell them medical school is not going to teach you what you need to know about that, right? They're not going to equip you to do the kind of advocacy work that Danny is doing, right? To address the structural issue. If anything, it's going to teach medical students to throw their hands up in the air and say, I can't do anything about the structural.
Right.
This is why I think the folks who are in medicine and are out in the street or supporting the protesters understand something really important in finding, here's the line item. The line item is here where we can actually finally get our patients, that roof over their head, that job, that food, and, the programs that allow that to happen. That's what we're seeing. And that's why I would say that this moment is giving more of an education to those graduate medical students who are listening.
Well, I want to stay with this. We're almost up on time, but we have to talk. We have to bring this back together in the context of what's been happening in the streets and with George Floyd. And I was just the fact that he had a coronavirus diagnosis and then 7 weeks later was murdered. I don't even know how to bring those two into the same frame. You're helping me understand that a little bit, but I guess one way to just sort of ask the question, Nick, to you to start, is just to go back to this sort of what you were talking about in your op-ed. Is just let's just look. What are the disparities between healthcare and policing in American cities today? Minneapolis or Philadelphia or Los Angeles. I mean, just to start with that, can you give us a sense of the scale of it?
Well, I don't know if I can get that. I mean, I would say that immediately, what George Floyd's murder brings or the sort of revelation that he had both coronavirus and as the victim of police brutality, it just shows the sort of proximity to and vulnerability to death by police or by coronavirus, right? Again, bring us into an analysis of what it means to be an essential worker, right? What are the sort of mandated work hazards, right? George Floyd he was a truck driver and he was a security guard, right? So here we are. We understand two ways in which every time he walks out of his house, he's exposed to these mandated work hazards, the police and the coronavirus. So that's one way that I'm sort of thinking through. I don't know if it's fully everything that I would, but that's where I'm at right now.
Mm-hmm.
I think I just saw, I was just trying to think about something I ran by earlier, and it said that, structural racism is a larger public health disaster than coronavirus. So if anything, that's what George Floyd's having coronavirus and then being killed by, a racist cop.
Yeah.
Danny, you were suggesting a minute ago, thinking about community, the health of the community and the safety of the community as being, I'm not sure if we use the word safety, but
Yes, use safety.
Right.
What makes the community safe?
Yeah.
That's important because right there, you're talking back to the notion of safety that seems to have been embodied in the claims for militarizing the police in the United States since 9/11, which has made us manifestly unsafe in many ways. The one we're talking about right now is what's been witnessed in streets of Minneapolis, and also in many other ways as well, which is not just restricted to those communities, but in this sense it is. So is this a moment of what's possible right now? Let me ask it that way. Is this a moment of possibility, Annie?
Well, we all hope it's a moment of possibility, and that people don't get exhausted and it just gets swept back under the rug, because those that are in power have the capacity to maintain their power and not to make any change. But for the confluence of the illness of this virus right now, and seeing the underlying disparities that were already there, that are revealed, that many of us have been fighting about and fighting over for so long, exposed by the virus, on top of this another horrific murder. It's not something that can be as easily forgotten. But we do then have we have this chance to really talk about the health of communities now that wasn't really there before, and thinking about, so there has been lots of conversation about how we don't need police to save, and we can police ourselves. We are essentially good and decent people, and we can take care of each other. But that also means having the means to be able to take care of ourselves, to be able to have a stable home, to have decent food, and decent education, and safe spaces, and places. So, I think this hopefully we'll be able to have more of that conversation, and people will be able to track differently, and in the understanding of why are these things are happening.
Nick, let me bring that question to you as we close out, because I think if you're just looking at public opinion polls right now, not the best measure, but it's one that we have. This idea, a lot of words up there: reform, defund, abolition.
Mm-hmm.
They're all gaining traction, apparently,
mm-hmm.
Not just in Minneapolis. That does indicate a rupture across American society with two things that had been inextricably bound, which is that more police equals more safety.
Mm-hmm.
Obviously, for generations, that hasn't made sense in any communities in America, but in other places, completely unchallenged. Just the two just absolutely are connected. I know you've been articulate about this, seeing this as a moment of opportunity, and also just being clear about how we talk and what kind of evidence we bring. So can you say a little bit to us about that?
Yeah, I mean, I do think that this is a moment of possibility. As a former union organizer, when I was training other organizers, you need three things to sort of create a moment of change. One is anger, and we definitely have that. Two is hope, and hope is a plan to win. The organizers who've been organizing for this moment around abolition and defunding the police are offering folks a plan to win, right? That's really concrete and tied to really a civics lesson in how to cut a budget, at this local level. There's definitely urgency in the last, so it's AHUY. So anger, hope, urgency, and the last thing is you. Every individual has to do something to be able to participate. And I think that only real change will come along if people really engage themselves in some sort of organization, civic organization that really advocates for the kind of change that people want to see in this moment. We saw it during the civil rights movement. And I think that is kind of what I hope comes out of this. And that's what I hope people transform their energy out on the streets into, is to actually, create some social structures that can actually sustain change. That's the way I see it. And the democratic thing about it is not up to me and my vision. It's up to, that sort of participatory democracy.
I'm going to remind people you've been listening to COVID Calls, and I think we're going to stop there because it's a really hopeful and inspiring way to draw this really great conversation together. I learned a lot from both of you, Danny Ritchie and Nick John Ramos. Thank you so much for joining me today for this hour. I want to remind people you can catch COVID Calls Monday through Friday, 5 o'clock. And stay healthy, everyone. Have a good weekend. Stay socially distant, and we'll talk to you on Monday.
Thank you.